Hey everybody, I am Julie Matheny, a speech pathologist and IBCLC lactation consultant. I am the face behind LA Lactation, and you are in for a treat for today. I am going to be talking to the amazing Dr. Shari Carroll, pediatric dentist extraordinaire. There's Dr. Shari. I'm going to, let's see if I can add her as a moderator.
It worked!
How are you?
Oh my gosh, I am so good. How are you?
Good. Thanks for having me on.
Oh my gosh, this has been way too long. I've wanted you to be on for like forever. I'm so excited. So
Me too.
for those of you who don't know, Dr. Shari Carroll is one of the most amazing, phenomenal pediatric dentists in the entire planet. She is my kid's personal dentist. I love her very much. But I actually discovered you years before I even lived here. You brought in the wonderful Melissa Cole from Luna Lactation to talk about tongue ties and baby tongue ties. Yeah. So you got rudely interrupted by your internet connection. Can you tell us a little bit about yourself?
Yeah. So I am a pediatric dentist. I've been working for about almost 15 years in pediatric dentistry. I have a practice in Redondo Beach. I also teach at Children's Hospital. I teach at the residency program there. I'm a mom of two. And I love working with kids. And the past 8 years, I've been doing a lot of tongue ties too with little babies and helping with breastfeeding. So it's been fantastic.
I love working with Shari because I know she's not just gonna cut, and we'll talk about that a little later. But she really is protective of babies, and I love it. And it's one of the reasons I send them to you. So I have a couple questions for you because I have you on here. So when do babies start getting teeth?
That's a very good question. So it's like a range. So everyone can go on Google and you're going to see these little charts of when teeth come in and come out. I usually tell parents that babies can get teeth as early as 4 to 6 months. And so it's super important. That's why we usually see the kids by 1 year old, because by then they have a couple teeth in. But it's not abnormal. Some parents are like, oh my gosh, my baby's 6 months old and they have no teeth. It's okay. Every kid, just like every other milestone, they kind of follow their own pattern, and that's totally okay. But in general, and even babies, people ask me about teething. Even though you don't see a tooth, a baby can definitely feel it moving in the bone. So 4 to 6 months, and sometimes even at 3 months, parents are like, oh, I think my baby's teething. They probably are.
So what do you normally recommend for teething? Is there anything that you're like, oh yeah, this is my go-to, or this is what parents usually find?
That's a good question. Definitely for the little ones, I love teething toys, and definitely, there's so much out there. I find in general, and I found this with my own kids, they actually didn't like the actual teething toys, like the ones that were frozen. Yeah, I like those. So those are like silicone, and you can put them in the refrigerator. And I usually tell parents, get a Tupperware container. Those are amazing. I like a Tupperware container. You put all those silicone ones in your fridge, so at least they're cool to the touch. Because I find babies like those more than the frozen things.
Yeah, frozen is too hard. I found if you put the squishy gel ones in the freezer, they get so rock hard that I don't like ice. I don't like chewing ice. It bothers from a temperature perspective. So yeah, I like from the fridge.
And it's still soft, so nice to the gums. And I usually tell parents that's the best thing. Not only does it numb the area, but it also, the more you chew with your gums, it thins out the gums, so it's easier for the tooth to cut through when it's ready. So yeah. I really like that.
I'm a big proponent of suck as a reflex is there for the first 0 to 3 months. And then babies want to focus on chewing from 3-4 months on. Not only does it prime them for solid foods, but it helps with teething. The more they get that pressure in the gums, the more it helps pop those teeth through.
Definitely. My big thing for teething is I tell people, there's a lot of teething gels out there. I usually tell parents to just stay away from it. The most popular ones, like Oragel, every couple of years it gets taken off the market, then it gets put back on. And so I usually tell parents it's numbs for 15 minutes anyway. So I'd rather have something cold in there and natural, and it works just as well.
A lot of parents too will recommend homeopathics like camellia or arnica or the teether tablets, but I find the teething tablets are really tricky for babies under 6 months.
Yeah.
Because it's like a pellet in there that if they swallow that, like that's right.
I know. And I usually say once they get to 6 months, if it's like interfering with sleeping or you're like, gosh, my baby's just like not eating, Advil or Motrin is always my in the pocket if nothing else is working. Once the pediatrician clears you that you can take the Advil or Motrin, it's just so much better. So
yeah, and that's a good point. You want to talk to your pediatrician because they will give you a dose by weight. So a 10-pound baby will need a different dosage than a 15-pound baby, and they should be giving you that at your well baby checkups. They'll be like, oh yeah, it's 2.5 mLs, which comes in these teeny tiny syringes. So do make sure you check with the pediatrician because it is done by your specific baby's weight.
Yeah.
Okay. So once those teeth poke through, when do you start teeth brushing?
So I usually say I like to introduce the toothbrush once you see like the full tooth in. It's really interesting. People parents don't know the tooth doesn't just appear. It's like a tiny little nub for such a long time. So it's really good to just get your babies in the habit. I like to introduce the toothbrush before you have to use it. Just like anything else, it's going to be different. Yeah. Yes, I love a finger brush. The banana brushes are amazing. It acts as double duty. It's like a toy too with nice little teether as well. Yeah. Those are fantastic. And it's just getting, like, your mouth has such a sensory rich environment. So the babies have to get used to having that stuff in there. Yeah. But once we see like the full tooth come through, I like to introduce regular bristles too.
Yeah. Yeah. For sure. My start was in speech pathology where we were all about oral care, and we would often in the speech world consider oral care starts at birth, right? So that babies are used to something in there. It could look as simple as a finger on the gums. Some babies will get that milk film on their tongue. So we are often encouraging, we don't want to overdiagnose thrush. That milk film can look like thrush when it's really just residual on the tongue. Yeah. So wiping that off gently with a little soft washcloth or one of these finger brushes can really help. Because what I often hear is, well, I didn't start brushing until I had a toddler, and that toddler is like an alligator, and they just like barrel roll, and they're like it becomes behavioral. Yeah. So when you start really young, they're just used to having something in their mouth.
Yeah, it's part of the routine, definitely.
Right, exactly. And how often do you recommend that for babies under 1?
So really, I mean, there's all this stuff out there. I like before bed. Just trying to get the teeth clean before they go to sleep. Obviously in the morning, if they're in a really good mood and they're into it, that's great to work it in. But I'm realistic. I had 2 kids, little ones. Just at least make sure that's when kids will get cavities is right before they go to sleep. And especially if they are getting fed right before they go to sleep too, you just want to get that milk off the teeth.
Yeah. Now, when do you recommend you kind of alluded to it earlier, but when do you recommend your first baby's dentist appointment?
So around 1. And a lot of parents are like, well, my baby only has like 2 teeth or something like that. One of the biggest reasons why we say 1 year old is because that's when your kids are getting really mobile. That's when they're really testing out, can I run? Can I walk unassisted? And every child will eventually fall and they'll bump their mouth. And sometimes I look and I go, what teeth were in there and what teeth weren't? So I want to have that baseline of what was there. And again, like kids are across the board of what teeth they have and what teeth they don't. So it's really, really helpful to have that baseline. But the 1-year-old visit looks very different than when we go to the dentist. The kids are going to usually we have kids lay back in the chair with like on top of their parent. Sometimes we lay them across our laps too. But what we're doing is we're looking to see what teeth are in there. I actually do clean them too. And then usually I will put a little bit of fluoride on if parents are cool with that too. And it just helps strengthen the teeth to help prevent cavities.
Cool. Now, you said a buzzword. A long time ago, we had a whole discussion about infant toothpaste, the pros, the cons, the risks, the benefits. So I do still occasionally have parents ask me about toothpaste, right? Because there are a lot of choices. There's risks and benefits, pros and cons.
Yeah.
If you could reassure patients, how are you having that discussion about baby toothpaste? What does it look like? How much is it? What are kind of choices out there?
So yeah, there is so much out there. Definitely for littles, like training toothpaste is the most common. So it's basically just getting your kids used to a flavor on the toothbrush. That's it. And there's a lot out there. One of my favorites is like the Dr. Brown's ones. It's pretty natural, and it comes with a little mini toothbrush too, so it really helps as well.
And what
Um,
age are you doing that? Are you encouraging like more like 6 months plus once they're on solid
Yeah.
foods for that?
Yeah. And even you can even use, like I said, like you can use the toothbrush before to start introducing them to just like the bristles. It's a really cute little, I think it looks like a giraffe or something like that. It's a cute one. And then as the kids get older, you're right, fluoride is like such a buzzword. There's so much out there. The reason why dentists even talk about fluoride, usually an adult dentist like doesn't talk about it as much, but it's really highly talked about with children. And the reason why is their enamel is so much thinner than our enamel. So kids' teeth get cavities much easier than adult teeth do. So they've done tons of stuff. Over the years, we've tried like xylitol. We tried all these different things to try and see what can help mineralize the tooth to help strengthen it. And really, it's fluoride. Fluoride's the best thing, especially if the kids are starting to get cavities. That's when we kind of talk about it. But it's very different than, people are talking about fluoride ingestion. That's usually in liquid and things you're swallowing. Yeah. The toothpaste and stuff that you go to the dentist, it's topical. It's just going on the teeth that you see, and it's just helping the teeth that you see. You're not swallowing. If a kid swallowed it and you did blood work, you probably would come back, like you couldn't even detect it at that point. So yeah. It's different than systemic fluoride that's like in your body that you're getting from ingesting things.
And I'm sure it does spark a debate in the dental community. Yeah. You see it, fluoride. That again is a discussion to have with your personal dentist. Yeah. Pros, cons, fluorinated water, the mineral sources you have, the area that you live, the kinds of water you're exposed to. But yes, there are fluoride toothpaste and there is fluoride-free toothpaste. Yeah. Lots of options.
And that's what I usually tell parents. Like, you should never feel forced to do anything. And so that's like one of the reasons why you go to the dentist at 1 year old, to have those discussions and kind of see what works best for you. And parents will tell me, is even toothpaste, there's like the typical Crest and Colgate, and parents that are like, oh, I want something more natural. There's tons of toothpaste out there that you can, Amazon has like such a good selection of like more natural stuff that doesn't have a lot of chemicals in it, and that's great too. There's a lot out there.
Yes, there's so many more products. It's
Yeah.
not just like one choice. It really does get to be your unique family system, your unique baby, your unique, what you're exposed to in your foods, your fluids, your waters, and all of that to really be making those choices.
Yeah,
for sure. Now, the big one for me is tongue tie. Yeah. Now, in the baby community, you really see people divided, that most pediatricians are not trained in ties, and you kind of hear in the parent groups, I went to my pediatrician, they dismissed me. Pediatricians will often refer to ENTs, ear, nose, and throat doctors, otolaryngologists, but again, it's hit or miss for whether they've been trained or not. Yeah. In your professional experience, why are pediatric dentists a great resource for tongue tie?
So, I mean, number one, we're just used to being in the mouth all the time. So that's, we're always looking in there. And, dentistry isn't just about teeth. It's about all your oral structures. So we're just really in tune with oral structures and how your tongue is functioning. And that was my biggest thing. I got into tongue ties for breastfeeding because I had an experience with my own child with difficulty breastfeeding, and it was because of a tongue tie. And I couldn't believe I'm a pediatric dentist and I missed this. Like, it was just unbelievable to me. And so, number one, so we're used to looking in the mouth, and we're used to evaluating the mouth even on young babies. And then the big thing is a lot of pediatric dentists, we use lasers. So that's another big difference between other, an ear, nose, and throat doctor will usually either clip or put sutures in. We're also used to, because I'm doing so many procedures on kids, we're not putting a child under anesthesia or anything like that to do a tongue release or a lip release. So those kinds of things. And then it's just the experience of the provider too. Just how many have they seen? How many have they done? I definitely talk to parents, and you know, not every tongue tie frenums are frenums. They're natural, they're normal in our mouths, and we're just looking for a certain type of tightness or restriction that's really interfering with feeding. And you know, most of the time too, I have parents fill out a pretty long form about what's going on at home, what's going on during feedings, and that kind of also adds to it as well.
Yeah. Now, is every dentist trained in that in dental school, or is that something that you have to get additional training
to get additional training. So, you know, in dental school, we learn about frenums. No, most dentists don't even use the laser in dental school. We don't talk anything about breastfeeding. You know, that you don't really get much children exposure in dental school. That's why I always tell people, you always want to make sure you find a board certified pediatric dentist, because you can get out of dental school and just say, I'm going to work on kids, and they're not trained in pediatric dentistry. It's an extra residency. It's just like when you go to your pediatrician, they go through a special residency after medical school to become a specialist. Same thing for pediatric dentists too.
I had no idea. I had just assumed that you did it all.
No. It's just because it takes like 3 hours for one patient in dental school. So they were like, they don't really expose you. You get very little. Maybe you treat a small amount of kids, but no little kids. And it's very rare. It's maybe 10 kids before they graduate dental school if they're lucky.
Wow. Yeah. Well, it's funny because that's how speech pathology is too, right? Like if you want to work, you usually have to do a clinical experience in pediatrics, but that often looks like a school setting.
Yeah.
And it really is dependent on your grad school's focus of like, do you actually even talk about feeding, swallowing disorders? You're supposed to, but I would say most grad schools, most speech pathologists haven't touched a NICU baby ever. You know, you have to go and see that additional
I always say there's so much to learn in school, so they have to kind of have a hierarchy of what they can teach you.
For sure.
So
now, the other big thing that I get asked about is I'm often, because breastfeeding is having problems, I'm often the one that's identifying, hey, I'm suspecting a restriction here. I can see a frenulum. It looks really short. We're having, 15 different symptoms. I'm going to go send you. I can't legally diagnose it, but I can tell you what it looks like, what it does, the symptoms it's impacting. And then I'm like, go see Shari. Bye. She's going to diagnose it because she can actually do something about it. But I get asked a lot, well, what if I don't release it now? So when in your practice, obviously, I'm sure you're seeing older children, toddlers, preschool, elementary school, where the tongue tie was never identified as a child. Are you catching a lot of ties later on? And do you recommend releases later? Or what kind of things do you see when ties aren't addressed as babies?
That's a really good question, because I do have this conversation with parents. Yes, on the scope of things, so tongue ties later on, sometimes with feeding solids, I've seen, basically when you're feeding a baby solids, they're taking their tongue and they're smushing the food left and right, and they're trying to smush it with their gums. So tongue ties can cause issues with feeding when you introduce solids. Yes, we sometimes see tongue ties causing speech issues, and usually I tell parents that's like kindergarten when they start doing speech assessments. And I had a kid that went through speech therapy where they take popsicle sticks under the tongue and you have to put it behind your front teeth to make those sounds. I mean, I'm talking to the expert here, but so yes, tongue ties can cause those issues later on. Sometimes and we talk a lot about sleep. So depending on the position of your tongue in your airway, we can have a lot of mouth breathing. That's definitely, on the scope of things, I tell parents, I look at it as I can have a 15-year-old walk in my office as a new patient and have a severe tongue tie, like the tip of their tongue cannot move out of their mouth. They've never licked an ice cream cone like we do, but the kid actually speaks completely fine and has never had an issue, which is interesting. And I've talked to parents, and it's not just happened once, it's happened multiple times. And so
I saw adults. I worked in the hospital doing feeding and swallowing, and part of my job was a complete oral motor exam on adults to see why they were having swallowing issues. I saw a lot of 50, 60, 70-year-olds with ties where their body had compensated for years, and every once in a while they had a stroke where now their compensations no longer worked. And it was like, your tongue, you compensated real well, but now that half your body is paralyzed, like your tongue isn't going to compensate for that anymore.
That's so interesting.
Yeah. I mean, because 60 years ago, tongue tie was a very different thing than now. The awareness was just different. If it was really severe, there were still some pediatricians that or midwives that would still just scissor snip it at birth.
Yeah.
But if it's what we consider more posterior in the mouth, less obvious, a lot of times it was just like, oh, they just didn't breastfeed well, bottle feed, formula feed. It was just a very different thing 50, 60 years ago.
It's amazing. And that's one of the things that I talk to parents about, because sometimes, you know, babies getting a procedure, it's going to be very different recovery than if you're doing it on like a 4-year-old. I think that there's a zone of kind of no-go too, where like these kids are, you know, it's hard. It's the recovery of getting the procedure done. The parents have to go in and stretch the area, and like there's just no way you can do it on like a toddler with teeth and like hold them down. And so we always talk about that. There's like a window to do it, and then as they get bigger, it just gets a little more difficult. And then you can go back later on and do it once they get a little bit more cooperative. So,
yeah. So, what's your typical age range for babies? Because I know historically I've sent you some slightly older babies, and all of a sudden it's like, oh, we have this window of time. When do you usually like to do your releases?
I think the best. So the earlier, the better in general.
Yeah.
I try and do it under 12 weeks. I find it's the most successful. It's easier for parents to get in there, really take care of the wound so it heals nicely. And the other part of it is it's easier for the baby learning how to use their tongue the right way. The more they use their tongue the wrong way, just the more difficult it can be to really get the hang of it. No matter, you can have the best lactation consultant ever. It's just harder work for the baby.
Well, and it's like what we talked about. Suck as a reflex is there for the first, 11 to 14 weeks, where its reflexes are blueprints to teach the body how to move. So that suck is you put something in the mouth and they want to suck on it.
Yeah.
Then doing it over and over and over, they learn muscle memory to do it. That shifts at 3 to 4 months, around 12 weeks. Where now they no longer want to focus on sucking, they want to focus on chewing. And it's all about moving the jaw more, moving the tongue more. So it's a really tricky age. And that then does become a much bigger discussion of what does that unique tongue look like for that baby? Is it really thin and stretchy? Does the tongue still have good mobility, or is it short and thick? Is feeding a complete derailment versus, it's going okay, but we want to try to improve it? That is a bigger discussion to have with your care providers, timing of that release. For sure.
Definitely.
Anything else that you want to talk to us or tell us about tongue ties? Anything that you see often that you're like, I really wish parents would know from a dental perspective?
So definitely for just with tongue ties, one of my other really big things, so I try and do it under 12 weeks if possible. And then just making sure, because there's so much out there, like, about, people think their baby is a tongue tie, and I always say if it is released, you should always have a good lactation consultant, because the babies don't magically know how to feed when you release the tongue. And so in my practice, I usually won't release the tongue unless I know if they're planning on breastfeeding, unless it's like a mom that's breastfed like 5 kids or, is a pro. I usually say you've got to have a lactation consultant on board too, even if it's just one time, just to get you going. Because I find, I always look at, I just want it to be successful. I'm putting a baby through a surgical procedure. I just want it to be worthwhile. So I think that's really important.
I think it's important. Well, I'm biased because I am a lactation consultant, but to work with one before just jumping and going to see a dentist, because there's so many things that actually mimic ties.
Yeah.
Tension at birth, torticollis, where there's tension patterns through the body, true low milk supply. It could look like so many weakness, so many different things, right? That mimic ties.
Yeah.
Where a lot of parents are like, I'm having all these issues into Dr. Google, what do I do? And a lot of times, yes, it is a tongue tie is the culprit, but sometimes it's not. And so they go to dentist hoping for a magic wand fix. They might have a dentist that's not as educated as you, that, you know, just is like, oh, you're in my office, I'm going to clip because you're here and you're having problems, who's not breastfeeding savvy, that doesn't understand the complexity of infant feeding. They now have a release and now feeding's even worse. Or they don't see an improvement in symptoms because, again, they're not realizing that it's often not a magic wand fix, and that it could be other things like tension patterns, asymmetries in the body, birth trauma, all of these other things that are contributing when it's not actually high.
Yeah, definitely.
Yeah. Oh, only other thing, because you're a dentist, and I sometimes hear this from dentists. It's just a reminder to everybody that breast milk does not increase the risk of cavities for night feeding.
Yeah.
Bottle feeding and breastfeeding do work very different. And I do often hear some other pediatric dentist telling parents to need to night wean by 1 or 2 because it's going to increase the risk of cavities.
I usually tell parents, if your baby is night feeding, just keep a wet washcloth next to you. And as they're drifting off to sleep, just gently wipe it, and it's okay. Don't wean. Don't worry about it. Yes.
But keeping a bottle in the crib overnight absolutely can increase the risk of cavities, because that milk formula, cow's milk, juice, sugars is really what causes the cavities. Those are the big things. Oh, one other last question, because I love to ask this question because you'll get different opinions from different people. Pacifiers. What's your opinion on pacifiers?
So that's a great question. So I am very pro pacifier. I like it. So I think babies need that non-nutritive suck. I think pacifiers is something that later on you can control. If a baby really needs to suck and you don't give them a pacifier, they're going to find their fingers, and their fingers move their teeth so much more. They move their jaws so much more. So I'd rather a pacifier than fingers. There's so many different pacifiers out there. And it really, you know, one of the things I look at, there's all these different nipples and sizes and shapes. And it depends on your baby's mouth. So one of the things we look at is when I do an exam looking for tongue ties, I look at their palate, and that really tells me I know what bottle is best for you and what's pacifier is best for you. Yeah. In the end, like, parents will go like, oh, I'm using an orthodontic pacifier, all of that stuff. They've actually done research in pediatric dentistry. It really doesn't matter what the nipple is. It depends on how heavy the kids suck over time. The heavier suckers really will move their teeth out. And then some kids just have it in their mouth all day, but it just lays in their mouth. And either way, the research shows by age 3, if you have dental flaring and you take away the pacifier, it goes back down. Isn't that crazy? Yeah.
Fascinating. Because you'll hear different perspectives from different professions, right? Like pediatricians technically follow AAP guidelines that say out by 6 months. Lactation consultants who are diehard will be like, never, it's the brat. Speech pathologists are like, it's okay as long as, it doesn't interact with speech. Yeah. Some lactation consultants are like, we want the round shape to promote tongue cupping. Sure. We want tongue up on the roof of the mouth and not down on the floor of the mouth. So you're going to hear different perspectives, which is why I wanted to know your perspective, because I love it.
No, I think it's okay. And it's definitely, it will change the shape of the upper jaw if they're really heavy suckers, like make a higher palate. But they've actually and again, I just look at the amount of kids that I see, and I sometimes think the higher palate, there is a genetic component in it. And sometimes I'm like, was that from pacifier use, or was that just your genetics too? And so I don't know. I am very pro pacifier.
I love the fact too, if you don't have the joy of living by Shari and having her as your dentist, she actually has a little mailbox for baby pacifiers. Because you can have your toddler mail their pacifier when they're done to a baby, and it's like the cutest thing for like pacifier weaning.
We love it. Yeah, we call it the pacifier mailbox. The kids get really into it, and it works every time. There's really good books about reading about it. I think that's the best way, is not doing it cold turkey, having the kids part of the process, getting them prepped for it, and it usually works out really well because they're okay with it. They know what's coming.
Yeah, never ever cut your pacifier tip.
We don't want to traumatize them.
Yeah, we don't want to it can cause a choking hazard. The only other thing I will say is I do recommend a one-piece pacifier, because some of these two-piece pacifiers where it's like the Bink and the different plastic, this can actually detach from the pacifier with those heavy suckers.
Oh, wow.
Where they getting teeth, they end up biting through because of those front teeth, and then they bite through the nipple and it pops off. So that's my only caveat, is if you have a heavy sucker and you're noticing damage, if you have a two-piece pacifier, that can be a choking hazard.
Yeah. Wow.
But anyway, thank you so much for coming on.
Thanks for having me.
Lovely. Yes. I want to have you on like every week because I love chatting with you.
Me too.
I love all your wisdom and knowledge. If you're down here in the South Bay of Los Angeles, definitely go see Shari. She's phenomenal. Her office is the cutest too. I mean, look at her wallpaper behind her. That's Instagram right there. Sometimes I like to go to Shari's office just to do Instagram posts because her wallpaper is so much fun.
We try and keep it fun and light.
I know, I love it. So anyway, thanks everybody for tuning in. Go like Shari's page. She's always got really fun stuff on pediatric dentistry. And I'm really glad you all joined us. And Shari, we'll talk to you again soon, okay?
Thank you. Thanks for having me.
Bye.
Bye.